Riley. My name is Ferah. I'm an RN in the NICU at Paris downtown. I happen to be the nurse that's taken the lead in this pain protocol in downtown. I work alongside with the cooks pain committee, and of course Dr. Riley and Dr. Schmidt and other doctors are also involved, and some NMPs of course.
Will you just speak louder so I
Oh.
make sure it gets on
Okay.
there? Since you're going to be projecting the other
All
one.
right. So I'm basically going to summarize what you will be expected to learn the coming months. It's a lot of re-educating. It's a lot of retraining the way you do things. There's some one-on-one activities and many PowerPoints to come, but we will take it very slow.
Yes.
Right? Okay, so this is basically a summary of what you will be seeing in the near future. So the FDA came out with a warning about repeated use of anesthetics and sedation in children less than 3 years old. It talked about the effect in the development of their brain, which is where this all initiated from. The pediatrics group got together and came up with new ways of sedating or providing sedations for the neonates. And we also stress about non-pharmacological interventions and try and use those more alongside of the medications. Is neonatal pain undertreated? So think about a healthy neonate that's a feeder grower, except he is learning how to bottle feed. So he has an NG tube in, and today you need to change out that NG tube. So what's the first thing that you do? You remove that tape. That's one painful procedure. The second thing you do is you remove that NG tube. That's a second painful procedure. Third thing that you'll automatically do is put the new NG tube in. That's the third painful procedure so far. It's a completely healthy newborn learning how to eat. You're basically simply just changing out that OG tube, but those are already 3 painful procedures that that baby got exposed to. So we're trying to pay attention more to the baby's pain needs. A sick baby, on the other hand, will have about 14 plus painful procedures, depending on how sick the baby is. If you think about the IVs, the LP punctures, the urine caths, the intubation or extubation or everything that goes on, and of course the Q2 to 4 canisters or sugars that you will be unsticking the baby for. Why does pain control matter? It causes impaired brain growth. It changes the baby's response to pain, impaired perception, and those are lifelong complications. Multiple invasive procedures a day, we've talked about that. How pain affects neonates as an adult. Poor growth, increased degree of injury, impacts their behavior and response to stressors in life. Pain, long-term pain changes the way the brain grows, the long-term behavioral effects. So we are asking you to, after you leave this meeting, to take control today, protect the future of those infants as much as possible. So this is just a summary of neonatal multimodal pain control, and it's a handout that you will all receive. It basically summarizes why we're doing what we're doing and how using different medications, low dosing together, can also give you the outcome that you are looking for. So it's something that we can, or you will be reviewing, and alongside with probably pharmacy and doctors when you get to the pharmacological teaching or interventions. It will make a lot more sense, but it's just something to look out for. Buzzy bee is a little bumblebee that is a buzzer. It is something that you will be trained on, one-on-one training. It will be mandatory. You cannot use it until you've been checked off on it. It's a little buzzer that you can use as a non-pharmacological intervention, and it has specific guidelines. That's why you will need to be trained on it so we do not cause injury to the babies. Now these guidelines or directions will be in your pods, laminated.
I'll put it on the reference rings.
Okay. And it's something that you can go back to when you use the Buzzy. I have it somewhere. So it's a little vibrating bumblebee. And you will be using this for shots, heel sticks, and venipunctures. That will be your training. So non-pharmacological interventions, they can be used with many things that we do in the unit. Examples of non-pharmacological interventions are skin-to-skin, involve the parents. If you're giving immunizations, for example, you allow the infant to be kangaroo held for 30 minutes prior to vaccines. You can leave the infant on the mom if you're comfortable with that. Give the vaccines. You can use the Buzzy alongside to that. So non-pharmacological interventions, you can use more than one method. You don't have to pick just one. You can combine a couple methods or more just to get that outcome. If the baby is too sick to be held and you need to do a venipuncture or a heel stick or something, and the parents are there, they can encircle hold the baby. They do not have to be picked up. Encircle holding also helps. Use of sucrose, you can use that alongside with everything else. We have developed specific guidelines to use sucrose. Melissa would look into that. And basically 1 to 2 drops 2 minutes before procedure, 1 to 2 drops right before the procedure, and then you can give some after. But there's a maximum in millimeters based on the infant's gestation. We don't want to overuse it. Older babies, music distraction, we use sound machines, we use DVDs, things that you guys have available is also something that you can be using. Breastfeeding helps. If you do not have sucrose available, EBM also helps. EBM has proven through research that it also has analgesic effects. Buzzy bee, of course. Later down the road, maybe we can even start incorporating massage, but that needs training, and that would be later down. So if you involve parents, they are a lot of help, and they love being involved and being able to make decisions for their babies. Pharmacological interventions. This, I think, Dr. Riley will go over in detail with different drips. You've got minor procedures, major procedures. They have their own guidelines, sedations. Weaning them also has specific guidelines, and avoiding withdrawal and NICU intubation. Dr. Riley will also go over. You will have a flow sheet to follow, and that will involve RTs, of course, and pharmacy. There are 4 different medications, and we have programmed them into our Pyxis, so we just remove them as a kit, and we just credit back what we do not use. And that's something you'll have to work with your pharmacy in doing.
Karen's working on
And then you
that.
follow the diagram, which you will be trained on. Back here is a summary for it. You guys will keep this poster, something you can refer back to. It explains the medications, the dosages, and the flow diagram. and that's the algorithm. So notice it has emergent, non-emergent, planned, and you basically just follow them. We have also pre-calculated the dosages based on the infant's weight, so each infant has a pre-calculated intubation sheet by their bedside, and that is something that you guys can also try and work on to see, and it just saves a little time than sitting down and calculating. So once you have passed the education about the pain and the pharmacological and the non-pharmacological interventions, you will be looking at a comfort menu. Now this is a menu that would be, for us, we place it on the infant's clipboards and we review it with the parents on admission. It's a way to involve the parents in the decision making. They can let us know which method they think is best for their baby to control pain. We have them laminated. We can use the whiteboard markers to circle, and then we can modify it later on when the parents decide that they think something else is better. It talks about comfort positioning, sugar water, which we will eventually be changing to the droppers. Right now we have the little cups, but we developed guidelines to follow based on the number of drops, which is why we're changing to the droppers. Distraction, we use DVDs on the older kids, and we have sound machines and mobiles, which we do use quite often. Swaddling, I think you guys use the sleep sacks also. Mm-hmm. That's a given. Buzzy you will be trained on, so that would be an option. Just remember, Buzzy is going to be for infants 34 weeks and greater only. So that's something that you have to discuss with the parents. We have started to use LMX4. It's similar to EMLA, but it has a faster reaction. We had to create a specific protocol for that, and it took us about 3 months to get it approved. So we actually have a policy for it right now on how to use it, and we require a qualified RN to use it, and that is somebody that will demonstrate based on it. So we're thinking about maybe putting it as a competency for some RNs. So it is something that you will need to work on also with your pharmacy. Do you have it available? The LMX?
No.
You don't have that available? Okay, something that you have to work on, okay. So that's only used for infants greater than 37 weeks, and we use it on LPs, the spinal taps, a lot. A lot of doctors have been requesting it now. And we haven't used it on immunizations, but our goal is to use it on that also after we train some of the nurses to use it. We don't want to.
Do you use it for IV starts?
No, they don't want it. They think that's too frequent to use, and so they don't want to use it. So yeah, they just picked the two. And then other methods, ask your provider, and you can discuss other things that you may want to use, or the parents may want to use with their infants. So here's your LMX. I have a summary. So basically, we talked about not to cleanse the skin, because it works best when it is mixed with the skin's surface oils. Wear gloves, of course. Apply the cream amount onto the site for about 30 seconds. Apply another layer. So they have found that LMX works best when it's a thick layer on the skin. So the second layer is what they decided. Do not flatten the cream. After the product is removed, the skin should be cleaned and prepared as usual. It starts working in about 30 minutes, so plan for it before applying it. Total application time usually should not exceed 60 minutes.
Do they
And-
use, I'm sorry, do they use Tegaderm to cover it for better absorption?
Correct. Our policy says, put the Tegaderm on, leave it for the 30 minutes, and remove it right before. Correct.
Oh, so that's why you say don't flatten.
Correct.
Got it.
So, Texas Health Fort Worth is working on the comfort menus. We're at the comfort menu stage. Cooks is past us. They actually have started massage. Are they doing the aromatherapy yet?
Not yet.
Okay. They got approved for the oils to use for the aromatherapy, so they will be using that. And then acupuncture, they got all the supplies in.
Do you know which oils they're using?
I don't have the list yet, but Dr. Gandhi is the one that's leading this, and so she will be directing everyone on how to use it. Yeah. So this, you may be seeing more things. We have our OTs went to a massage conference, so we have them ready to start teaching when we get to that phase. This is ongoing. You may see new things. This is just where we are at right now. There's more to come, I'm sure. Yeah. So that's it for me. If you have any questions, let me know. I will be here.
Thank you.
Switch